البروفيسور شرف أبو شرف نائب أطباء لبنان ببيروت، البروفيسور عامر عبد الله والبروفيسور علي حسن شمس الدين. تحياتنا إلى البروفيسور هاني محيدلي من إسبانيا، للدكتور إبراهيم عبيد من بوردو من فرنسا، وخاصة للدكتور ريان سعد من السنغال، ولأول مرة أفريقيا عم بتشارك معنا بهيدا النشاط. Also, good afternoon to all colleagues from North and South America, particularly to Dr. Joseph Karam from the States and to Dr. Ramez Matar, who is joining us from Sao Paulo, Brazil. Finally, good morning to all attendees from Eastern Asia and to Dr. Walid Ahmar from Australia. والآن يسرني أن أستضيف وأقدم البروفيسور شرف أبو شرف نقيب أطباء الذي سيفتتح هذا اللقاء الرابع والمخصص لمعالجة ولجراحة الأمراض العظام والمفاصل. بروفيسور أبو شرف الكلام لكم، تفضل.
مرة جديدة بشكركم جميعا، بشكر الإلما بشخص دكتور وليد أحمر، بشكر دكتور جوزيف بخاش بالجهد اللي عم بيقوم فيه مشان تحضير المحاضرات، والسي ام اي اللي عم تتقدم عبرهم. وهيدي شغلة مهمة كتير لنا بنقابة الأطباء حتى نقدر نكمل بالطريقة العلمية اللازمة بالكفاءة والجودة اللي تعودنا عليها رغم كل الظروف الصعبة يلي عم نقطع فيها حاليا. ما رح فوت بموضوع الليلة، انتو أفضل مني بأنه تحكوا عنه. رح أحكي بالمطلق عن المشاكل اللي عم نعاني منها هلأ وبسرعة، خاصة فيما يتعلق بهجرة الأطباء يلي عم بتصير أكثر وأكثر من يوم ليوم. يلي عم نشوفها بالنقابة صار حوالي 3000 طبيب تارك لبنان إلى دول العربية أو الدول الغربية، مع الأسف أكثريتهم من الكفاءات العالية واللي نحن بأمس الحاجة لها. كنا بنتمنى أنه هالكفاءات هاي تبقى هون وتتساعد لحتى تبقى هون، ما تتساعد بالهجرة، تتساعد بالبقاء بلبنان والتعاون معنا حتى نقطع هالمرحلة الصعبة اللي قاطعين فيها. المشكلة الثانية اللي عم نعاني منه يلي بعتقد سمعتوها مؤخرا، التعديات أكثر وأكثر على الأطباء، على القطاع الطبي التمريضي الاستشفائي اللي عم نشوفها بالمستشفيات، بأقسام الطوارئ، بالعناية الفائقة وبالعيادات الخاصة. آخرها اليوم على طبيب أسنان أودت بحياته مع الأسف، رغم كل شيء عملنا قبل، إن كان من حيث القوانين لحماية القطاع الصحي ومن حيث تطبيقه ومن حيث الحماية من ناحية القوى الأمنية والعسكرية والإعلامية والقضائية. مع الأسف لحد هلأ ما كان في جدية كافية للتعاطي مع هالموضوع. منها أعدنا الاتصالات المكثفة مع المعنيين، سياسيين، أمنيين، عسكريين، قضائيين، لحتى بالسرعة الممكنة نعالج هالآفة هاي، هالظاهرة الخطيرة هاي يلي إذا ما كملت رح تؤدي إنه إلى كتار من العاملين بالقطاع الصحي يتركوا ويفلوا أو ما يشتغلوا، خاصة إنه العمل اللي عم بيقدموه بالإجمال هو عمل مجاني أو شبه مجاني. منها ضروري نتعاون كلنا سوا للحفاظ عليه بأسرع وقت ممكن، وسوا بالتضامن والتعاون اعتقادي قادرين نقطع هالمرحلة الصعبة اللي عم نمر فيها بأقل ضرر ممكن، بأقل كلفة ممكنة. مرة جديدة بتأمل إنه نوصل لحل سريع لهالقصة، وبشكركم على كل الأعمال العلمية اللي عم تعملوها، إن كان بالإلما وإن كان عبر اللجان المختصة والجمعيات المختصة بنقابة الأطباء بلبنان. شكرا. دكتور بخاش الكلمة إلك.
بشكرك دكتور بروفيسور شرف. أظني دكتور يوسف نقطع الخط تبعه ونكمل بالبرنامج بالويبينار. On behalf of the International Lebanese Medical Association, I want to thank you all for coming with us tonight, being with us tonight. Good evening, good afternoon, and good morning to those from joining us also from Australia. We are proud to partner the Lebanese Order of Physicians in the series of webinars. This particular series and today will be on orthopedic surgery, innovations and updates. And once again, we have a world-class number of presenters, and it is an honor to have them with us. Orthopedic surgery, as we know, is quite critical and important, and it's a role that can actually help improve the quality of life of all our patients. As Professor Sharaf says, Lebanon is going through a difficult period in its time, and especially the health sector. They are hemorrhaging doctors overseas and losing them. And we want to help. The International Lebanese Medical Association wants to partner with the Lebanese Order of Physicians in these series of webinars. This is the fourth series that we are holding. It's on orthopedic surgery, and we will continue them. And whatever we can do as a International Lebanese Medical Association to foster linkages and to support our fellow professionals and colleagues in Lebanon, we're willing to do this. And we will partner you with any aspect that you believe is appropriate academically and clinically. And I'm proud to have with us these four speakers tonight, as well as the two moderators, Dr. Amar Abdallah and Professor Hani Mahadli in Spain. I also would like to thank Dr. Shamsuddin, who will also be co-moderating. It's been an honor to have these series of talks, and I will give back the chair to the next speaker, to Dr. Yusuf Bakhosh, to introduce the co-moderators, or one of the co-moderators.
So thank you, Dr. Walid, for your speech. And I would like, on behalf of the Lebanese Order of Physicians, CME, Continuing Medical Education members, to present to you our gratitude for all the efforts you are giving and all the time you are investing to make this project successful. أما بالنسبة لموضوع حلقتنا اليوم، واللي هو تحت عنوان ما هو الجديد بعالم جراحة العظام والمفاصل. ما بنقدر نحكي عن هذا الموضوع إلا ما نفكر ونضوي على الأوضاع الاقتصادية والمالية اللي هي عبء على القطاع الصحي تبعنا، وخاصة على هيدا الاختصاص بحد ذاته، اختصاص جراحة العظام والمفاصل. ليش؟ لأنه العمليات الجراحية والمداخلات الجراحية بهيدا الاختصاص بتستوجب استعمال مفاصل اصطناعية وصفيحات معدنية. اليوم كلفتها هي على عاتق المريض اللبناني مباشرة. ووقت بنتأسف إنه نعرف إنه عدد هيدي الجراحات بمستشفياتنا كثير تراجعت، وخاصة إنه عدد الأشخاص اللي كانوا عم يستفيدوا من التأمين الصحي الخاص تراجع عددهم من 400,000 شخص إلى 50,000 شخص بلبنان. هلا كل هيدي الصورة الضبابية هيدي ما بتمنعنا إنه نتعلم، إنه نحاول نطبق كل الأبحاث الجديدة والطرق الجديدة بهذا الاختصاص. ولكن نحن كنقابة أطباء علينا كمان إنه نفكر ونشتغل مع الأجهزة المعنية أو الجهات المعنية، من نقابة أصحاب المستشفيات الخاصة، من وزارة صحة، من نقابة مستوردي الأدوية والتجهيزات الطبية، لحتى نلاقي مخرج لهودي الأشخاص اللي عم بيعانوا من مشاكل مفاصل وعظام، وبنقدر نسمح لهم إنه يقدروا يستمروا إنه يستفيدوا من نوع من العلاجات والجراحات الطبية. وهلا بيسرني انه استقبل البروفيسور عامر العبد الله الاخصائي في جراحه العظام ورئيس الجمعيه اللبنانيه لجراحه العظام لافتتاح هذا اللقاء. دكتور عبد الله، الكلام لحضرتكم.
Thank you. Good evening, good afternoon, good morning. Hello. Sorry. Okay. First of all, I would like to welcome Professor Sharaf Abu Sharaf, and I would like to thank Professor Yusuf Bakhash, and I would like to thank Dr. Walid Ammar and the ILMA for all the efforts they make to make this webinar a reality. I would like to thank each one of our speakers, and I would like to thank you all for taking the time to join us this evening. From our side as a Lebanese Orthopedic Society, in this difficult and challenging time, we decided to go forward. We decided that going online would be a very important thing in this situation. That's why we decided to invest in our website and also to invest in our app. That's why I invite you to go and to visit our website and to download our application. You can find it on Google Play or Apple Store. It's a very interactive website. You can go on the forum of this website. It's a very interactive one. You can post cases and we can make discussions. And we think that this is a good way to interact between us as a surgeon in Lebanon and abroad. And that's it. This is all what I want to say. I thank you, and I am sure this will be a very interesting webinar. Thank you.
Thank you, Dr. Abdallah, for this introduction. And now let me introduce our first moderator, Professor Ali Hassan Shamsuddin. Professor Ali is a professor in orthopedic and trauma surgery. He was the former head of division of orthopedic and trauma surgery at the Faculty of Medical Sciences at the Lebanese University from 2012 to 2020. He was the past vice president of the Pan-Arab Orthopedic Association and the past president of the Lebanese Orthopedic Association. Dr. Shamsuddin got his medical degree in 1984 from Saint Joseph University in Beirut, and he was graduated from France in orthopedic and trauma surgery in 1989. He got also from 1989 and 1982 additional expertise in sports medicine, in sports surgery, in foot and ankle pathology, and in hand and upper limb surgery. And recently, in 2007, he got an MBA in health management. Also in 2009, he was assigned fellow of the American College of Surgeons. He contributed and wrote more than 40 articles and presented more than 157 presentations. And he was assigned to chair many meetings in orthopedic surgery at a national, regional, and international levels. Thank you, Dr. Shamsuddin, to be with us and to accept moderate this session. Now, Walid, if you can present the second moderator, please.
Thank you, Yusuf. It's with great pleasure that I introduce Professor Hani Mahadli, who is also a close friend and is also part of the International Lebanese Medical Association board. He's an associate professor of clinical orthopedic surgery and works at La Palmas in Spain. He's completed a spine fellowship at the Johns Hopkins University in Baltimore. He's a chairman of Spine Deformity Committee of the North American Spine Society. Henny's also been a past president of the Association of Iberian and Latin American Spine Societies, also past president of the Spanish Spine Society, and was a member of the board of directors of the Scoliosis Research Society from 2016 to 2018. Henny, it's a pleasure to have you with us tonight to be a co-moderator. Henny, I would like to ask you to introduce our first speaker. Henny, if you can please unmute.
Thank you, Walid. I would like to thank ILMA for their efforts and for their kind invitation to be part of this event. I'm happy to co-moderate this session with Dr. Ali Shamsuddin. And we'll start with the first. We have 4 interesting speakers, 20 minutes each. And at the end of the session, we will have questions and answers. So please don't hesitate in sending your questions, and we'll catch it and we'll discuss it at the end of the session. So we'll start this session with Dr. Joseph Karam. He is assistant professor of orthopedic surgery from orthopedic surgery at the University of Illinois, Chicago. He underwent residency training in orthopedic surgery at this university, and then he did a fellowship in the very prestigious Rothman Institute in adult reconstruction, hip and knee arthroplasty, and now he is assistant professor of orthopedic surgery at the University of Illinois, Chicago. He will be presenting a prosthetic joint infection prevention and diagnosis. Please, Joseph, you may start your talk.
All right. Just gonna share my screen. Can you guys see my screen?
Yes.
All right. All right. First, I would like to thank the committee for having me here. I would like to thank ILMA USA for having me represent them for this webinar, and it's a real honor to be here with all of you today. My talk will be on periprosthetic joint infections of the hip and knee. How can we prevent them in 2022? I have no significant current disclosures for this talk. Why is periprosthetic joint infection such an important topic? Studies have showed that periprosthetic joint infection is the first reason for revision surgery in the early phase after total knee replacement surgery within 2 years post-op, and the second cause overall after aseptic loosening in chronic cases. Hip replacement, similar situation, periprosthetic joint infection is the second most common cause of revision in the early phase and the third most common overall. Some of you may be familiar with these graphs. The demand for total hip and total knee replacement is expected to grow and even grow exponentially in the upcoming years. So we have to be ready to face a periprosthetic joint infection, which is becoming even more and more relevant. Periprosthetic joint infection is not only a highly morbid situation for the patient, requiring multiple surgeries, sometimes severely affecting the outcome of joint replacement surgery, but we even showed a few years ago that it can lead to increased mortality. In this paper, we showed that there was a almost six-fold increase in mortality at 1 year in patients undergoing surgery for periprosthetic joint infection versus revision surgery for aseptic cases. So multiple factors can contribute to the risk of periprosthetic joint infection, some of them host-related, some of them environment-related. And I just wanted to go over a list of some of these preventative measures and go over the guidelines and the current evidence for those practices. Most of the guidelines will be based on the International Consensus Meeting for Musculoskeletal Infections. So the second rendition of this meeting happened in 2018 in Philadelphia. We had over 800 delegates from all around the globe, and as you can see, Lebanon was represented in that consensus meeting, and the proceedings of this meeting are really guiding our treatment nowadays and how we perceive periprosthetic joint infection. There was also a European consensus specifically on prevention of periprosthetic joint infection, and we'll touch base on some of their statements throughout this talk. So I'll start by looking at some of the preoperative measures to prevent periprosthetic joint infection. First off, with skin cleansing. So both the international consensus meeting as well as the European meeting advocate for home cleansing prior to elective hip or knee replacement surgery, with a preference to use a chlorhexidine-based soap or scrub solution. This systematic review meta-analysis that included 6 studies showed a significantly improved rates of infection when patients did a scrub at home before coming in for elective surgery. How about steroid injections prior to hip and knee replacement? This comes up often, and according to the international consensus meeting, an injection within 3 months of you guys can still see my screen, correct?
Correct.
Okay, all right, I just got a message. All right, so injections within 3 months are considered an absolute contraindication for elective joint replacement surgery. They even recommend that injections that happen between 3 months and a year prior to surgery could constitute a relative contraindication for elective hip or knee replacement surgery. Some of the work has been done by the team led by James Brown and UVA. This here shows their study on total knee replacement based on the Pearl Diver database, which is an insurance claims-based database. They included over 35,000 cases, showed a significantly increased rate of periprosthetic joint infection if the patient had an injection within 3 months prior to surgery. They also found the same thing when it came to total hip replacement, again, almost 35,000 patients. How about obesity? So this team from the Mayo Clinic looked at obesity and its effect on complications and outcomes after knee replacements. They had over 20,000 patients from a single institution. And here you can see that there's a dose-response relationship between BMI and the risk of infection. And above a certain BMI threshold, around 40 of kilogram per meter square, there's actually an exponential increase in the risk of periprosthetic joint infection. So this study, as well as other studies, led to the recommendation to delay surgery in patients who are morbidly obese with a BMI over 40. The ICM meeting even considers a BMI over 50 to be an absolute contraindication for total joint replacement. So is sending these patients for weight loss prior to surgery affecting the outcome? There's not enough evidence really to say that, and even the international consensus meeting states that there's limited literature to really know that if these patients undergo bariatric surgery, if that will really affect the outcome. However, it is good to know that these patients are at significantly higher risk of prosthetic joint infection. Glycemic control is an important factor, especially that diabetes has been a well-established risk factor for periprosthetic joint infection. It comes into play both at the preoperative as well as perioperative stages. Up to 20% of patients undergoing elective total joint replacement arthroplasty are usually diabetic. 1/3 of them have undiagnosed dysglycemia, so either diabetes or prediabetes, and they're not aware. So this study from Rothman even showed that in patients who were not diabetic, perioperative blood glucose levels affected the risk of periprosthetic joint infection, with a 3-fold increase in the risk of periprosthetic joint infection if the blood glucose was above 140 on postoperative day 1, and this is in non-diabetic patients. They pursued their research looking at over 5,000 patients, and they showed a dose-response relationship between blood glucose and the risk of periprosthetic joint infection. So usually the hemoglobin A1C is used to screen patients for proper diabetic control, and a threshold of 7.5% is usually recommended prior to proceeding with elective total joint replacement surgery. However, there are several studies that didn't really show a strong relationship between HbA1c and the risk of infection. Recent research suggests that fructosamine may be actually a better marker to reflect glycemic control close to the time of surgery and help predict the risk of infection in these patients. And again, another paper from Rothman Institute with Jay Parvizi showing that a fructosamine threshold was really more reliable than HbA1c in predicting the risk of PJI, with a 6-fold increase in risk of PJI with a fructosamine of 292 micromole per liter. And again, 1/3 of the patients with high fructosamine were not diabetics. So this can be relevant even in non-diabetic patients. So we talked about preoperative factors. Like I said, glycemic control is overlap between pre-op and peri-op, but I'll keep going with some of the perioperative factors that can affect the risk of infection. So first off, antibiotic prophylaxis. As you may know, prophylactic systemic antibiotics are actually one of the most important factors, if not the most important factor, that allowed us to significantly reduce the rates of periprosthetic joint infection, if you look at it historically. The recommended agents are usually first-generation cephalosporin. In the United States, most commonly that's cefazolin. Alternatives are commonly used in allergic patients, such as vancomycin or clindamycin. This has to be administered within 1 hour of incision, and this is in line with the WHO guidelines and the SCIP guidelines. 2 hours for vancomycin, since it can take an hour to infuse. And the dose has to be appropriate, and these medications have to be redosed appropriately, and this is more relevant in complex cases and long revision cases. Again, these antibiotics are sometimes underdosed, and this is really important because the study showed that when these in underdosed patients, there was a significantly higher risk of periprosthetic joint infection, and this mostly happens in obese patients where the dose needs to be adjusted. Vancomycin, in addition to being used as an alternative, comes into play in patients with high risk of MRSA. It is less effective than cefazolin against MSSA, so that the current recommendation is to use it as an adjunctive to cefazolin in patients who have high risk of MRSA. So still give the ANSEF and add vancomycin in patients who are high risk of MRSA. Indeed, studies showed that in patients who received vancomycin instead of cefazolin had a higher risk of periprosthetic joint infection. And this study from the Mayo Clinic, again, about 30,000 patients, they compared patients receiving cefazolin preoperatively versus other antibiotics such as vancomycin and clindamycin. They found a significantly higher rate of periprosthetic joint infection in patients that did not receive cefazolin. So the current recommendation, and recently the American Society of Anesthesiologists joined the Orthopedics Society in these, is to really spend every effort to give these patients cefazolin, even if they have a penicillin allergy. In cases where there's a true anaphylactic reaction to penicillin, or if there's an actual reaction to cephalosporins, they should be sent to allergy preoperatively, because we should spend every effort to clear patients to receive a first-generation cephalosporin, as this can really affect their risk of infection. Very hot topic recently, how many doses of antibiotics, how long should antibiotics be administered? So the CDC came up with the updated guidelines for the prevention of surgical site infection in 2017. They hadn't updated them since 1999, actually. So in 2017, they came up with updated guidelines. And they said that even in orthopedic surgery, even joint replacement, they would recommend the use of only 1 preoperative dose of antibiotics. They do not advocate for the administration of subsequent doses. The American Association of Hip and Knee Surgeons, backed up, of course, by the American Academy of Orthopedic Surgeons, came up with a statement disagreeing with that and stating that the standard of care is still to administer antibiotics within 24 hours post-operatively. And this is reflected in the consensus meeting. However, since then, there have been efforts to try to better understand this situation. There's an ongoing prospective study led by Thorsten Saylor at Duke, trying to better elucidate this. And since then, there have been several retrospective studies, the one on top from Rothman, looking at 20,000 primary total joints comparing single dose versus multiple dose of antibiotics. They found the same rate of periprosthetic joint infection at 1 year. Study with more than 240,000 patients based on the Dutch arthroplasty registry, same rate of revision for infection. And finally, a study from Dartmouth, again, same rates of 90-day periprosthetic joint infection in single dose versus multi-dose antibiotics. There's some bias in these studies. A lot of time, the patients receiving the single dose are same-day discharge patients or healthier patients, but still there seems to be a lack of evidence to support multiple doses of antibiotics, and we're all awaiting the outcome of the trial that is led by Duke University. Moving on to talking about the operative environment, this large study from the New Zealand Joint Registry showed really an elevated risk of infection with the use of surgical helmet systems and laminar airflow, which we usually use in an effort to reduce infection. But actually, there's no strong evidence to support the use of these. This meta-analysis looking at laminar airflow showed that there was actually an increased risk of infection with the use of laminar airflow in total knees and total hip arthroplasties. The team by Mark Spangella from Mayo, Arizona, looked at surgical helmet systems. Again, there was no difference in rate of infection, even a tendency towards significance for a higher rate of infection with the surgical helmet system, which is a positive pressure system, but however, it is the most commonly used. So when they looked at body exhaust suits, which are similar to the ones used by Charnley historically, these are negative pressure systems. So these systems do lead to decreased contamination, decreased rate of infection. However, they are bulky and they're not really widely used. So again, the international consensus meeting states there's not enough evidence to support the use of laminar airflow or the use of personal protection suits or space suits or surgical helmet systems. We do like them, however, because they do offer significantly better protection for the surgical team. Operating room traffic is still a major problem in joint replacement. Again, a study from Rothman showed on average 135 door openings during revision cases, which is a very, very, very high number. A different group from that same institution used the particle counters in the OR and showed that there was a significant increase in particles in the air in the OR with more door openings and more personnel in the room. They did show a significant decrease when the laminar airflow was turned on, but again, every effort should be made to reduce traffic in the operating room and reduce the number of people in the room. This is supported both by the ICM and the European consensus with a 99% consensus. Multiple strategies can be implemented to limit the traffic in the OR. Many of these were studied by teams like from the Anderson Clinic and showed to be efficient. How about skin preparation? So the study from the New England Journal of Anti-Surgery compared chlorhexidine alcohol versus povidone iodine and showed that chlorhexidine-based solutions were much more effective at preventing surgical site infections and clean contaminated surgery. This was not limited to orthopedic surgery. However, the biggest critique of this study is that they compared chlorhexidine alcohol versus povidone iodine, but the povidone iodine did not have alcohol in it. So that they cannot attribute the difference to chlorhexidine on its own because it had alcohol in it, which is why the international consensus meeting recommendation does not think there's a difference, but as long as alcohol is included in the PrEP solution. Same thing with the CDC guidelines. The European consensus, however, does not think that all antiseptic solutions are equal and still gives a preference for chlorhexidine-based solution as opposed to betadine-based solutions. But again, the most important is that these need to include alcohol to optimize the prevention of surgical site infections. Since the study came out of Rush University, the use of dilute betadine irrigation intraoperatively has been common practice, at least in North America. And this was recently backed up by a much wider study with over 30,000 cases and strong statistical analysis, including multiple confounding factors that showed that there was a role for dilute betadine lavage intraoperatively to decrease the rates of infection. And again, this is also supported by the ICM as well as the 2017 CDC guidelines. Blood management is very important around the time of joint replacement. Multiple studies have showed that transfusions increased the rate of infection. Meta-analysis, again, supporting this. The ICM supports this. So multiple efforts are being spent to limit blood transfusion, which brings us to talk about tranexamic acid. So one of the reasons to use it is to limit transfusions, limit bleeding, and also decrease surgical side bleeding and hematoma formation. As stated here by the European consensus, every effort should be spent to decrease hematoma in order to reduce the risk of infection, and tranexamic acid comes into place, and that's how it's thought to reduce the risk of infection. And again, the literature supports this. So these papers came out after the international consensus meeting. The first one is an institutional study showing significantly reduced rates of periprosthetic joint infection with the use of tranexamic acid. The second one is a very wide database study from HSS, including over 900,000 joints, with 50% almost reduction in infections when tranexamic acid was used. VTE prophylaxis, again, plays a role in this context because different agents can have different risk of bleeding, especially with the recent emergence of aspirin as a preferred means of VTE prophylaxis and joint replacement. And again, the literature shows this. These authors compared aspirin use versus warfarin, and they showed a significantly lower rate of periprosthetic joint infection in patients who received aspirin for DVT prophylaxis after joint replacement surgery. Finally, the use of surgical dressings. So the ICM recommends using occlusive silver impregnated dressings to decrease the rate of surgical site infection. The European Committee advocates for the use of advanced wound dressings. They don't really detail what they mean by advanced, but there clearly is a role for the type of dressing used to prevent infection. We were one of the first teams to show the benefit of using a silver occlusive dressing with hydrocolloid to decrease the risk of periprosthetic joint infection, and our findings were further corroborated by others, like this further study by the team from Colombia. More and more surgeons are resorting to the use of closed incision negative pressure wound therapy or incisional wound vacs in high-risk cases. There's still limited literature. A randomized control trial from the Cleveland Clinic showed decreased wound complications and infections in patients undergoing revision joint replacement and that were at high risk of wound complications. So these were patients with BMI above 35, use of anticoagulants, diabetics, smokers, patients on immunosuppressants or corticosteroids, transplant patients, malnourished patients, etc. They then followed their efforts with a multi-institutional study. That's the second one in the middle. And that included very high volume institutes such as Cleveland Clinic, Rush, HSS. And again, they showed decreased 90-day complication in patients who received a closed incision negative pressure wound therapy versus a occlusive silver impregnated dressing. And finally, meta-analysis, also including 8 studies, showed decreased surgical site infection after revision joint replacement. They did not show a significant difference in primary surgery with, however, an increase in blisters in these cases. So you have to be cautious about the increased risk of blisters when using these devices, but they seem to have a role in patients who are at high risk of having wound complications postoperatively and may have a role in decreasing the rate of periprosthetic joint infection in high-risk patients. So in conclusion, periprosthetic joint infection results from an interaction between host factors as well as environmental factors. Prevention is still the best medicine, as it is a truly devastating complication to happen in an otherwise really magnificent surgery that we do. So our duty is to optimize the hosts preoperatively, relying on the identification of modifiable risk factors and acting upon them, and to practice evidence-based medicine in the OR and while managing the patients very operatively. All right, thank you for your attention.
Thank you very much for this excellent presentation, Dr. Karam. We'll have some questions at the end of this meeting. Next is Dr. Ryan Saad. He is orthopedic and trauma surgeon from Sheikh Anta Diop University of Dakar. He has also a diploma in sport medicine from Paris, ortho and trauma surgeon at the Clinic of Bellevue, Dakar. And he will be presenting an original surgical technique for reconstruction of chronic Achilles tendon rupture.
Okay, hello everyone. Can you see my presentation?
Not yet.
Hello.
Can you share your presentation?
Yes.
But it is not in the screen.
Dr. Ryan, if you can share your screen, please.
Yes.
On the green button.
On the green button.
Down, yeah.
Okay. Sorry. On the green button.
Ryan, if you go down the bottom, where it's got mute, stop audio, there's a green button that's got share screen. So if you open up your presentation on the Zoom, if you open up your presentation, then go to the Zoom down the bottom, there's a green button, it's got share screen. It's next to chat and reactions in between.
That.
Have you opened up your present? That's it, right? It will get there. Good. So just excellent. Double click it and it will come up full screen. Good.
Sorry. I am actually sharing my screen. It is written, but I don't see. You don't see my screen actually?
Yes, but you have to double click in order to see the full screen presentation. Double click there.
Yes.
Or yeah, on the double click. Or if you go down on the right hand side, you see like a small screen bottom, just push it and you will see full screen and then your presentation down. On the right hand side.
You can see it actually?
Yeah, we see it, but you have to put all the presentation at a full size screen.
Here, like that?
No, we don't see it. Yeah. But double click there.
I'm really sorry, everyone.
No, go down on the right hand side and you see, down a little bit more, and you see a small, bit more, no, bit more. At the end, go at the end.
Here?
No, now, before, there. No, before, there.
Here?
Okay. Perfect. Go ahead.
It's okay now, so you can start, Dr. Ryan.
Okay. Okay, I understand. I will just apologize for this delay. I just want to ask you to allow me to do the presentation like that because I am a Francophone and my English is not so fluent and I need to be guided with my what I have written before.
Go ahead.
Okay. So good morning, good afternoon, and good everyone. It is a great pleasure for me to be with you today. I am Dr. Saad from Dakar in Senegal, West Africa, and I am an orthopedic surgeon at the Clinic Bellevue. I'm really happy to be with you to share this moment with the ILMA and with everyone because I am a young surgeon and it is a great honor to be with this masterclass, world-class speaker today. I would like first to thank Dr. Walid Ahmar to inviting me to be a speaker today. I would also like to thank all the members of the ILMA who participate to this webinar and to make this association active. So as I say, my English is not so good. I will do my best. Few days ago, when Dr. Ahma told me about this webinar, I didn't know exactly, because I'm a private surgeon, not at the university. And I've been thinking about one of my patients that I am actually following. And I wanted to share with you this case, enabling us to talk about the surgical management of chronic Achilles tendon rupture. It is more a discussion than an academic presentation. And I have changed the first title because first I wanted to speak about a chronic rupture of large tendon, but it would have been too long. So to introduce this subject, we can remember that Achilles tendon's rupture is the most common rupture of large tendon in the body, more frequent than patellar and quadricipital tendon. An important difference must be made between acute in one side and chronic rupture in the other side. By chronic, we mean more than 6 weeks after injury. While it is frequent to see patients with acute rupture, it is less common to see chronic one. And these patients are seen in case of delayed diagnosis or failure of non-operative. This rarity pushed orthopedic surgeons to try many surgical techniques. In the literature, we can find around 40 techniques, and this makes the literature quite poor and don't allow medical and surgeons to adopt a global consensus on how to take care of this patient. For the treatment, the difference between acute and chronic is very important. For acute rupture, it is possible to choose between non-operative and operative treatment, depending on your patient's age, his level of sport activities, his job. And for the operative technique, this could be percutaneous technique or by open procedures. However, for chronic rupture, surgery by open procedure is the only way to treat this patient. This type of surgery could be done with augmentation or without augmentation. In most cases, it is with augmentation by using something. It could be a tendon, it could be a fascial flap, it could be a graft. It is to reinforce the repair. And sometimes for the tendons, usually we can use the flexor hallucis longus, the peroneus brevis, or the plantaris muscle. Fascial flaps can be used as turn-down flaps or advancement flaps that we all know. For the grafts, it can be autograft, for example, using a graft of fascia lata, or synthetic graft by using different material like dacron, polyglycol, or carbon fiber. These are a few illustrations of the used techniques. So at your left, you can see the plantaris muscle plastic, where you cut it proximally and you realize a lacing of the tendon over the rupture. At your right, the peroneus brevis transfer, where you disinsert distally the tendon, you pass it through the calcaneum, and you suture it to the medial side of the calcaneum and over the rupture. The Bosworth technique is a fascial flap technique, the most known, where the tendon strip is freed from the aponeurosis of the gastrocnemius, left attached proximally, turned down over the rupture, and sutured distally. At your right, this is the modified Bosworth technique, less known, where the tendon strip is passed through the proximal end of the tendon transversally, thereafter through the distal end, and finally go back and suture to the proximal end of the tendon. Another technique of fascial flap or tendon strip is a Lindon technique. The illustration on your left show you the Lindon technique. So it is a two tendon strip, lateral and medial strip, and like the Bosworth technique, they are turned down and sutured to the distal end of the tendon, usually to reinforce a primary end-to-end suture. At your right, the VY plastic, that I think we all know the technique. So you cut a V flap in the tendon proximally, and you can pull it out, pull it down to suture the rupture, and you close the donor side. Finally, an autograft. Here I choose a picture of a fasciolata graft at your left, and a synthetic graft. There is many types. Here you can see the graft before is using and after the reinforcement of the suture of the Achilles tendon. All of these techniques could be used alone or combined. It depends on your intraoperative findings. It is, like we say in French, a treatment à la carte, meaning that you could decide to use this one or this other technique on a case-by-case basis, depending on your patient. This small introduction allows me to present you a case of one of my patients that I took care 2 years ago, and for who I used, I think, original, or maybe a new technique. I don't know exactly. I don't find in the literature a technique like that. But like I said before, it is a discussion, and maybe some of you have ever heard about a technique like that. So this is a patient of 31 years old, a teacher, big amateur football player, and it is really a tall and strong guy. He had a left Achilles tendon rupture during football game and was treated by a non-operative technique with an inclined plaster during 6 weeks by another colleague. And after the removal of the plaster and the beginning of the physiotherapy, this patient felt that there was a problem with his ankle. He came to my office 9 weeks after the acute rupture. On the clinical examination, he was unable to stand on tiptoe. Brunegage and Thompson signs were positive. He was painless, but we can notice a slight limp and a decreased strength of the calf muscles. At the ultrasound, we noticed a complete rupture in the body of the tendon with a large gap estimated around 5 centimeters. So the diagnosis was evident. It was a failure of the of the conservative treatment, and we decided to operate it. But what were the specificities of this patient? Management consideration. It is a young patient with a high level of sport activities, a large gap the ultrasound, and probably for who direct suture it is impossible. So we choose to use the Bosworth technique, and the surgery happened 11 weeks after the initial injury. We used an extended post-surgical approach. Subcutaneous tissues were freed. The paratenon was really difficult to individualize because we find a massive fibrotic gang around the rupture. After opening this gang, tendon rupture, the distal and proximal ends of the tendon and the proximal gastrocnemius muscle were exposed. We did a large debridement of the exposing very well the two stems of the tendon, and we leave intact the walls of the gang to use it after, because we probably cannot find the paratenon. So we could use it like a new paratenon to separate the repair from the skin. So at this moment, the question was what to do. The initial choice, the Bosworth technique, was impossible because during the debridement of the lesion, we did a too large debridement in the midline of proximal end of the tendon, which has weakened the tunnel side to take the central tendon strip. So the Bosworth was impossible. The VY-plasty seemed insufficient to cover the gap because it was a large gap of minimum 5 centimeters. Tendon transfer, we didn't want to do it or to do a tendon plasty because we were not very comfortable with these techniques, and synthetic grafts were not available. So thinking about what, and without ever having heard of Lindon technique, I figured myself that I cannot use a central tendon strip because too damaged, but it would probably be possible to use two smaller strips medially and laterally instead of the Bosworth technique. We raised two tendon flaps from the gastrocnemius muscle, laterally and medially, approximately 1 centimeter broad and 10 centimeters long. These flaps were left attached proximally around 2 centimeters and twisted 180 degrees backward on themselves so that the smooth external surface lies next to the subcutaneous surface as we turn it distally. This was to prevent adhesion to the overlying skin. Then they were sutured at the proximal on the aponeurosis to prevent the extension of the incision distally. After that, individually, the flaps were sutured on themselves like a tube, and then sutured, the two tubes were sutured together to obtain what I call a strong new tendon, and not only a bigger flap. Then we put this one inside the tube formed by the remaining fibrosis tissues, so this tube could replace the paratenon after its closure. Thereafter, we did tendon and the distal end of the tendon using a classic Kessler suture. And we completed this one by a continuous suture while controlling the plantar flexion of the ankle. We then close the proximal defect in the gastrocnemius aponeurosis, and the cutaneous tissues and skin were closed with a redond drainage. Finally, we applied a cast in Equinus gravity. This is a small video showing you the medial strip of tendon left attached proximally. You can see this is an extended posterior. Okay, this is the medial strip. Here you can see the two strips. This is the lateral one. So I am cutting it. And I want to show you at the end, it is freed. And we have the two strips. Sorry for the quality of the video. I was not the cameraman. So here you can see the two strips. We check that it is enough to cover the strip. And finally here, we are suturing them together after suturing them on themselves to make tubes. I don't know if you can see it very clearly. So we are suturing them together. This is the final aspect where you can see here the new tendon is like a real tendon. And here you can see the fibrotic walls that we leave intact to put the tendon inside. Here you can see that the distal end of the new tendon reach the distal end of the first tendon. We put an equine plaster for 3 weeks, and after healing and removal of the stitches, we put a neutral plaster for another 3 weeks. After 6 weeks, we remove the plaster and start physiotherapy, the classic one, with partial weight bearing for 3 weeks. Sports were not allowed, and I saw the patient 3 months after for the evaluation. And what were the outcomes of this patient? He was painless, walking without limp. There was a full range of motion. He was able to walk on tiptoe and to stand on tiptoe on upright side only. He was then allowed to start sport activities progressively, very carefully, and was able to play football after 6 months at the same level as before. And I'll show you here the results, where you can see the scar, the dorsal flexion. This is symmetrical. The plantar flexion, it is also symmetrical. The calf, with not so much amyotrophy, and the physiological position in a slight equine position. fait normal. Aucune boiterie. These are the results. Voilà, il peut faire de demi-tour, il est très bien, il peut marcher sur la pointe des pieds. Hein, la pointe des pieds, aucun problème. Voilà. So he can walk without any problem and can stand on his tiptoe. Le pied gauche sur la pointe des pieds. On one side only. So de la force. A good strength of the muscles. What is innovative, or maybe what I find innovative? Hello?
You can continue, Ryan.
Okay. So what is innovative? The first thing is to use the fibrotic walls of the gang as a paratendon and to reinforce also the new tendon, the repair of the tendon. And the second thing is to suture together the two strips to create a real new tendon. And as described first by Lindholm, to put it on the lateral side to just reinforce. Here it is to construct a tendon. So it is maybe what we can call a modified Lindholm technique. I don't know. I did some research on the books and literature, but I don't find a technique like that. To conclude, we can say that repair of chronic Achilles tendon rupture are not so common. Many surgical procedures have been described in the literature, mixing different techniques. You just have to decide what would be the best for your patient, depending on the specificity of the patient. It is, like I said, it is to show you this example, that maybe it is original, and show you how I manage it while facing an unexpected intraoperative difficulty during the surgery. It is an encouraging result for this patient, but more patients have for sure to be collected to do a serious study on the outcomes of maybe this new technique. Again, I would like to thank you all, dear colleagues, for your attention. And I am actually finished this presentation.
Okay, thank you, Ryan. Nice illustrations. We'll have some questions at the end of this interesting paper presentation. I would like to ask Dr. Shamsuddin to present the other two speakers, and I would like to have a special mention to for the next speaker, Dr. Ibrahim Abaid. Is one of the best spine surgeons in Europe. A special welcome to him. And I would like to Dr. Shamsuddin to present the other two speakers. Ari, are you there? Walid, do you have the presentation? Can you present the? If he's not there, can you have the?
I have the presentation of Dr. Ibrahim. Dr. Ibrahim, welcome on board. We are really happy to have you with us. So I am going to, as you have said, Dr. Ibrahim is working in Bordeaux, France, and he is really well known, and we are proud to have French doctors from Lebanese descent doing such a great work in France and all over the world. He is a professor at the University of Bordeaux, and he is specialized in spine surgery. So I am going to try to share my screen and to put the presentation on. Is it okay?
No, we don't see.
Look, wait.
Now.
Okay, I am going to start it from the beginning. Okay.
Can you hear me?
Yes, we can hear you, Dr. Ibrahim, but we can't see the presentation.
Okay, so
if you have it, you can share the screen.
I can share it from here.
Yes, thank you for that. Thank you.
Okay, I'm happy also to see you all, and I will try to find it because it was not planned like that.
So you see the presentation or not?
No, we don't see the presentation, but Dr. Obaid is going to look at it and will share it with us.
I will share it directly. I think it's easier.
Okay, please.
No problem. I hope. Okay. Ok, partager l'écran. Surgery principles in AIS. In this conference, we will approach the surgical treatment of AIS. We will define surgical indications, try to find the ideal timing of surgery, give a summary of the most used classification which correlate with the choice of the curve to fuse and fusion limits. At the end, we will develop briefly surgical techniques and some frequent errors which could be avoided. Surgical indication depends on the magnitude of the curve, the progression risk, and the response to orthopedic treatment. The cosmetic and psychological aspect should also be evaluated and discussed. Progression risk is increased in thoracolumbar or lumbar curve with coronal malalignment that can lead to lateral stasis at early adult age. For this reason, surgery may be indicated for curve less than 40 degrees in the specific situation. If we look to this diagram where the growth velocity is represented in blue and the curve progression in red, we can identify an ideal period to operate. This period should be after the peak height velocity and as earlier as possible on P2 slope in order to avoid severe progression. This interval is represented by the green arrow. If the curve progresses quickly, despite orthopedic treatment, and if the patient is still squeletally immature, surgical treatment preserving spinal growth is indicated. This is especially true if triradiate cartilage is open. In this situation, multi-level spinal fusion should be avoided. Many growing rods solutions are now available. The pros and cons of each of them is beyond the objectives of this course. Another skeletal maturity index is the Risser sign. Its advantage is the possibility to measure it on the X-ray used routinely for scoliosis itself, and it doesn't need to do another X-ray. The risk of postoperative complication related to growth decreases dramatically after Risser 1. So surgical timing is a matter of balance between the curve progression and the remaining growth. We try to operate before a major progression, but also not too early in order to avoid major loss of height. We may schematically give these recommendations for patients having surgical indication. For young patients with Risser 0 and open triradiate cartilage, we recommend to use a growing-friendly technique. If triradiate cartilage is closed, we recommend to wait until peak height velocity is reached, which correspond to Risser 1 and mean arch. If Risser sign is 2 or more, deformity correction and fusion is recommended. Many classifications were developed for AIS. They are correlated to the surgical technique used at the same period of time. For example, King classification was correlated to the use of Harrington rods, and each type gave an indication of treatment according to Harrington principles. Linke classification is the most used one since the development of segmental correction technique by Cottrell and Debussy. Linke classification is based on 4 standard radiographs: standing full spine AP and lateral views and lateral bending films. It defines major and minor curves. Minor curves may be structural or not, that depends on their flexibility. According to Linke classification, there is 6 curve types depending on the major curve location, and an important parameter is the lumbar modifiers. Lumbar modifier is correlated to the indication for including or not the lumbar curve inside the fusion. It is an essential parameter in the decision-making, especially when a selective thoracic fusion is planned. This classification provides a template for analysis of the radiographic component of scoliosis and a basic guidelines for the surgical treatment with respect to the region of the spine to be included in the instrumentation and fusion. As any classification, there are some limitations, especially concerning lumbar spine. When surgery is indicated, the surgeon should always start by answering the first question, which is, which curve should I fuse? Then he can go to the second step to choose the levels. This order should be always respected, and surgeon should not think about fusion levels before deciding the curve which have to be fused. That help to avoid many technical errors, as I will show you later. Generally, the major curves should be fused, but there are some exceptions.
Oh, sorry.
Surgery. Exception is still the same. Lumbar curve and Linke 1C. When indicated, the surgeon should always start by answering the first question, which is, which curve should I fuse?
Ibrahim, we're not seeing your
second
presentation at all.
Okay, I will do it again. Okay.
To choose the levels. This order should be always respected, and surgeon should not think about fusion levels before deciding the curve which have to be fused. That help to avoid many technical errors, as I will show you later. Generally, the major curves should be fused, but there are some exceptions. It is the case of a double major scoliosis when the lumbar curve is flexible. In this situation, selective thoracic fusion may be indicated. Minor structural curves are also generally fused. The exception is still the same, lumbar curve and Linke 1C, when thoracic selective fusion may be indicated. The goal of these exceptions is to maintain lumbar spine flexibility. If a selective thoracic fusion is decided, the surgeon should avoid to include a part of the lumbar curve inside the fusion. He should aim a partial thoracic curve correction in order to avoid postoperative coronal malalignment and lumbar curve progression. The improvement of the lumbar curve may be progressive and may not occur immediately after surgery. The patient should be warned of the different scenario and possibilities in case of lumbar curve progression. Once you select the curve to be fused, the next step is to choose the upper and the lower fusion limits. The fusion should include the entire curve, so it should not be shorter than the end vertebra indicated by the Cobb angle. The selected vertebra should have small or no rotation. For the upper instrumented vertebra, the apex of the thoracic kyphosis should be avoided. The lower instrumented vertebra should not be at more than 1 centimeter of distance from the central vertical sacral line. I would develop two specific situations. The first is the fusion in type 2 double thoracic curves, and the second is selective fusion in Lenke 1C curve. In Lenke type 2, the decision to include the proximal thoracic curve depends on the 6 criteria cited above. The first two are the most important. If the decision was not to include it, the upper instrumented vertebra should be as low as possible to leave enough mobility in the proximal thoracic segment in order to permit a spontaneous correction of the shoulder height. The aim of including proximal curve is to avoid postoperative junctional kyphosis between the two thoracic curves and to avoid the postoperative shoulder imbalance. The correction should be harmonious between them, and the correction of the proximal curve is often difficult. This is an example of a Lenke type 2. The proximal thoracic curve met the criteria to be instrumented. Harmonious correction allowed a good shoulder balance. We can also notice that the flat thoracic spine is corrected and a harmonious thoracic kyphosis is restored. That is very important for cosmetic reason. In contrast with the old knowledge, full screw construct is able to restore thoracic kyphosis. In Lenke 1C or 2C and some 3C, selective fusion may be indicated. The goal is to obtain a mild thoracic and lumbar curves. It is very important to respect some rules to avoid postoperative coronal malalignment and lumbar curve progression. First, the lower instrumented vertebra should be the stable vertebra of the main thoracic curve. Second, any vertebra from the lumbar curve should not be included. Third, don't overcorrect the thoracic curve because the lumbar curve would not be able to compensate. And at the end, we should be patient at least 1 year post-op to obtain the final result. In this example of Lenke 1C curve, a selective fusion was performed. As you can see, the rules we just cited were respected, and we can observe a moderate correction of the main thoracic curve, a spontaneous correction, and a progressive improvement of the lumbar curve. We can also notice that the thoracic kyphosis was restored using a pedicle screw construct. Before surgery, a consent form should be signed and an MRI should be realized to rule out any spinal or intraspinal anomaly that may change the idiopathic nature of the scoliosis. This example shows a mild syrinx associated to a type 1 Chiari malformation. Careful and controlled reduction is necessary to avoid neurological complication. Careful attention to the skin is mandatory, and back acne should be treated to decrease infection risk. In the photo, you can see an example of skin acne to be treated before surgery. The planning should be clearly presented and easy to be seen during surgery. It should include patient identity, name, date of birth, pathology, fused level, X-ray or CT scan, and any interesting finding like 6 lumbar vertebra, Chiari malformation, coagulation anomaly, etc. Surgical planning is essential for any scoliosis surgery. All possible difficulties should be diagnosed and action to palliate to them should be prepared. There is no time for thinking during surgery unless an expected event occurs. All the steps should be executed as planned. The upper instrumented vertebra and lower instrumented vertebra should be clearly identified. The pedicles to be instrumented should also be defined, especially if their size is small and specific technique has to be used, like navigation or in-out-in technique or sublaminar bands or other type of implants. The surgeon should keep in mind that the aim of the surgery is to correct the deformity and to obtain fusion, and it is not necessarily to put a certain amount of screws or implants. In case of difficulties, hooks, sublaminar bands are a good alternative solution and should be ready for use. In this example, you can see the use of sublaminar band at the apex of the concavity and the hook at the convex upper instrumented vertebra. Navigation may be used in specific cases, as you can see in this example. The proximal and distal screws were inserted using freehand technique. The apical dysplastic pedicles was instrumented using image-guided navigation. Positioning is important, especially for posterior approach. Attention should be taken for the eyes, elbow, and shoulder to avoid compression or traction. Abdomen should be free from any compression to avoid high venous pressure and bleeding. Femoral pedicle compression should be also avoided by checking the posterior tibial artery pulse. All the contacts with the operating table should be soft to avoid any cutaneous lesion. Everything should be done to avoid patient temperature loss before starting the surgery. That may increase bleeding and infection risk. Concerning the surgical field, I recommend to drape wider than expected in case the approach should be extended for any reason. Personally, I drop C7S1 systematically in AIS. Neuromonitoring should also be used. The anesthesia protocol should be free from inhaled gas and from muscle relaxant. In AIS, motor evoked potential, surgeon-controlled are sufficient. In case of prior neurological compromise, more complex neuromonitoring may be necessary during surgery. MEP should be controlled after each surgical time and especially after dangerous action. In case of severe deformity, MEP may be controlled several times during correction. Because of the possible delay of MEP changes, they could be controlled at least 20 minutes after the end of the correction. This is an example of severe curve correction. We can see a loss of MEP signal on the left lower limb. A decrease of the correction permitted a complete MEP recovery. Concerning surgical technique, we will take as example a posterior approach with pedicle screw instrumentation using freehand technique. I divided the surgical procedure in 6 steps. We should not start any new step before the end of the previous one. The first step is the approach, and 2 informations are essential. The first one is the meticulous bleeding control to avoid excessive blood loss, which may compromise the quality of the next steps. The second is the protection of the proximal facets and spinous ligament to avoid adjacent syndrome. The second step is facet resection that has 3 advantages. The first is that it provides deformity release and allows an easier correction. The second is that it permits to show and to prepare the anatomical landmark for pedicle screw insertion. And the third is that it permits to obtain a large amount of autologous bone graft. In our experience, we did never use bone substitute or allogenic bone graft or iliac crest in adolescent idiopathic scoliosis. Step 3 is implant insertion according to the preoperative plan. Step 4 is deformity correction. Many reduction techniques may be used. In all of them, 2 rules are essential. Don't put stress or forces on one implant in order to avoid implant pullout or bone fracture. Control MEP frequently during this step. The picture shows a typical case of simultaneous reduction on 9 implants in a thoracic curve that allows stress distribution and avoid mechanical complication during surgery. Bone graft is essential to obtain fusion, and bone bed should be prepared to receive bone graft. The left picture shows how to prepare fusion bed by removing the posterior cortex of the lamina called decortication. The right picture shows the end of step 5 with bone grafting using the local bone, only spinous process, facet, and posterior cortex of the lamina. The last step is 3-layer closure. The protocol are center and surgeon dependent. In our department, we use irrigation with diluted betadine, and we don't use a drain. We added vancomycin powder on 3 layers: bone, muscle, and subcutaneous tissue. For skin, we use skin stapler. The first wound dress is changed at day 4 before discharge. Anterolateral approach was used frequently in the past in Linke 5 curve. The advantage was that it permitted a shorter distal fusion and to save the L3, L4 level, as you can see here in this case. The other advantage is that it permits a direct and very powerful derotation of the vertebral body, as you can see here. These two advantages are now compensated by posterior vertebral derotation using high density pedicle screw instrumentation, as you can see here in this case. At the end, I would show you some frequent errors that may be easily avoided. And let's start with this case of Linke 1A curve. Classically, lower instrumented vertebra may be L1. But when we look to the sagittal plane, we can notice L1, L2 kyphotic disc. And in this case, it is recommended to stop on L2. This is another case of Linke 1A. The end vertebra is L2. The surgeon decided to stop distally on L1, which is shorter than the end vertebra. L1 is also at more than 1 centimeter distance from the sacral central vertical line. We can see the occurrence of a postoperative adding on syndrome with a progressive coronal malalignment, which eventually required fusion and extension to L3. The message from this case is that the fusion should cover the entire curve, at least from end to end vertebra, also called cob to cob vertebra. This is a Linke 1C case. The surgery performed included the whole thoracic curve, T4 to 11, and 2 vertebra from the lumbar curve, T12 and L1. Immediate postoperative coronal alignment occurred and progressed with time. I think that in this case, there were 2 possible strategies. The first one was to choose a selective thoracic curve fusion, and we stop at T11, which should be my preferred strategy. Or we may include both curves, and at that time, we should do from T4 to L3. The mistake done here was including partially the lumbar curve. As a take-home message, I may say that surgery is indicated for curves more than 35 to 45 degrees, depending on the location and risk progression. Linke classification is the most used and correlate with surgical strategy. When a curve should be fused, the fusion should cover it entirely. Posterior approach and pedicle screw instrumentation is now the gold standard of AIS surgery. Meticulous planning and respecting some easy principles permit to avoid many complications. Thank you very much for your attention.
Okay, thank you. I hope that the sound was well, and I'm waiting for your question. I think after the whole meeting, I think.
Yes. At the end of the session, Brahim, we will have some questions just after the last speaker.
Okay,
Ali,
Dr. Ali, you are unmuted.
Yes. Sorry for this inconvenience because I was muted by the host. Now I am unmuted, and I missed to present my my friend Brahim Abeid. Brahim, who is a very renowned and worldwide prominent orthopedic spine surgeon. Thank you, Ibrahim, for this very nice presentation. And now we will move forward, and it's a pleasure to introduce Professor Rames Matar from Sao Paulo University in Brazil. Professor Rames Matar is the head of Hand and Microsurgery Division and the head of Trauma Division in Sao Paulo University. He is also director of Microsurgery Laboratory and a member of the Scientific Committee of the Sao Paulo University Faculty of Medical Sciences. Professor Matar was appointed the president of the South American Federation of Societies for Hand Surgery in 2004 and 2005. He was president of the Brazilian Society for Hand Surgery in 2003 and Secretary General of the Brazilian Society of Orthopedic Surgery and Traumatology in 2002. Professor Matar contributed to more than 50 publications in the literature of the last decade. Professor Ramez Matar will be talking about creating a center of hand surgery and reconstructive microsurgery. Please, Dr. Matar, you can start your presentation.
Okay, thank you so much for the invitation. I try to share my screen just now. So, are you seeing my screen?
Yes.
Yes.
Okay, perfect. So thank you so much for the association, for all the organizing committee. It's a great honor for me to participate in this webinar. I work part of my time in a public hospital. It's a university hospital in São Paulo. We have basic equipment and materials, but we have a lot of lack of resources and investments. And now we have 20 professionals training hand and reconstructive microsurgery working around the clock. You know, Brazil has a natural beauties, beaches, forests, rivers, diversity in flora and fauna. And São Paulo is the biggest metropolis, is a city for business, gastronomy, culture, and shopping. But we also have a lot of problems. And one of the problems is a crazy traffic. Brazil has 200 million inhabitants. The city of São Paulo, we have about 12 million. The great São Paulo, 21 million inhabitants. And the state of São Paulo, 44 million inhabitants. So it's big country, big city with many people. At 2010, we have 2.7 deaths per day in the state of São Paulo. And now, 2021, we have 28 deaths per month, almost one per day in the city of São Paulo. So it's a big problem. We have an epidemic of severe trauma. And about publication, about epidemiology of trauma, the incidence of severe trauma in 2010, when we started this big group in Scandinavia, was 30 to 50 severe traumas per 100,000 inhabitants. So if Brazil were similar to Scandinavia, we would have 100,000 new cases of severe trauma per year. In the city of São Paulo, we would have almost 30 cases per day, but the situation is much worse. So we see very bad cases like this, very severe open fractures treated in an inappropriate form. So the patients have very bad situations, and most of the patients are going to amputation. In 2008, we have publications about the lack of hand surgeons and microsurgeons working in the emergency care centers. And I believe this is true for most of the countries in our world. And we start in 2010 working with hand surgery and microsurgery in the emergency in the city of São Paulo. And the goal was to have treatment in the acute phase of the trauma that we know is the gold moment to obtain better results, to decrease complications, incidence of infections, to decrease hospitalization period, and to decrease the cost of the health system. Then we know that most patients who do not receive adequate primary care will have a lot of complications, sequela, and it will be necessary to have sophisticated and expensive techniques to treat these patients. So in the first year that we start, we see that the number of microsurgical procedures in open fractures increase, the number of reimplantations increase, because we are at that time and till now the only one center in São Paulo, I believe in Brazil, that work with hand surgery and microsurgery, working at the hospital 24 hours a day. The infection incidence in open fractures decreased in the first year, and we're very happy about this index. About reimplantation, we don't have statistics, but in Sweden, there is 14 amputations of the upper extremity per million inhabitants. That's the index in 2010. So if Brazil were Sweden, there would be 3,000 upper limbs amputated per year. In the state of São Paulo, 610, almost 2 amputations of upper limb every day. And we know that 70% of the cases is possible to do reimplantations. So I can show you some cases that we treated here in São Paulo. This is a motorcycle accident amputation of the arm. Is a macro reimplantation. That's the functional result. That's a kind of accident that we see here is a avulsion amputation of the forearm. We needed to debride that muscle. We needed to treat all vessels and nerve with grafts. We needed to suture this tendon in the proximal muscle, and we can achieve good functional results in this kind of situation. This is a very bad accident with avulsion type injury, amputation of the forearm. And this patient has also an open fracture of the humerus. You can see here, and that's the first phase of debridement, vascular repair, bone fixation. The patient followed with a necrosis of the skin. So we transferred an anterolateral free cutaneous flap, and that's the functional result. And we needed to compare our reimplantation with the best prosthesis that we can give to the patients here in Brazil. And believe me, this is a good functional result for the patient with a very bad injury. This is another amputation, is a distal forearm amputation. We treat with Kirchner wires because in the public hospital at this time, in this day, we do not have plates to fix the fracture. So that's the early result and the final result. And the patient is able to use the hand for the work, for the daily activities. You can see here. We have a lot of wrist level amputation because we have a lot of industrial machines that cause this type of injury in the city of São Paulo. This is a case that we have a very nice functional result. The patient come back to work in the same machine that provoked the accident. This is another patient with a wrist level amputation and a very nice functional result. This patient comes from another state with a wrist amputation, 18 hours of ischemia. It's a cold ischemia, but the patient developed some epidermolysis and some problem with intrinsic muscles. But you can see that he has a good functional result to return to work. This is another case of wrist level amputation, and that's our best results, the best level for reimplantation. This is a little bit more difficult because we have a transmetacarpal amputation. We have intrinsic muscles. We have the palmar arch. We needed to do more microanastomosis to achieve perfusion for all fingers. But you can achieve a very nice result with this kind of surgery. And I can show you also what happens in Brazil. This is an engineer that have a 2-finger amputation in a machine. So in the initial care, was just regularization. The patient arrived home, talked with his wife, and his wife convinced him to come back to the hospital, ask for the finger, and go to another hospital, to the public hospital, to have a finger reimplantation. It was possible to do just 1 finger reimplantation because of the shortening for the regularization. So that's the functional result after 3 months of the rehabilitation. 2 fingers amputation, distal to the interphalangeal joint, good functional result. A very distal amputation in a heavy worker, but it's a very, it's difficult, but it's a 2 to 3 hours surgery and a nice result for this patient. 4-finger amputation, usually is 3 to 6 hours every finger. After 16 hours, we achieve reimplantation of our fingers. This is another case, 20 hours surgical procedure to achieve surviving a good functional result for all fingers. This patient has a segmental loss of the finger, so it was necessary to choose the longest distal stump to the longest proximal stump to have one finger reimplantation to give to the patient the function of the pinch. This is a ring avulsion injury, and you can see here that it's possible to see a vessel. So if you have a vessel, you can graft all the vessels of the distal stump to the proximal aspect of the hand and achieve a good result. But it's a very difficult injury, a very bad injury, serious injury. Almost 50% is not possible to do the reimplantation in this situation. We always try to do thumb reimplantation, 2 fingers, but distal amputation. If you can achieve good result of both fingers, you need to reimplant both fingers. But in this situation, more proximal, you can do the thumb reimplantation, and you don't want to have a rigid index finger. So we amputated the index finger and have a good functional hand in a heavy worker. In this situation, we have a very bad distal stump of the thumb. It's not possible to reimplant the distal stump of the thumb because we have a very serious injury here. We put the distal index stump to the proximal stump of the thumb to have extratopical reimplantation to achieve good function of the range. This is a thumb avulsion in a child. In this situation, we try to see if you can transfer a vessel, and we transfer the lateral digital artery of the index finger because we have a good pollicis princeps artery, so it's possible to transfer this artery. But in a more proximal amputation, we don't have the pollicis princeps, so we do not have the lateral digital artery of the index, so we needed to transfer the medial artery of the middle finger for the thumb. We can transfer also vessels of veins of the dorsal aspect of the hand to the thumb. This is another situation, is avulsion amputation of the thumb. We also use the vessels of the third finger to donate perfusion for the thumb. And this is another situation, the patient has avulsion amputation of the thumb, a severe trauma of the hand. This patient also has a trauma in the pelvis. This patient has a problem with hemodynamic status, is a hypovolemic shock. And after compensation, we treat all lesions of the hand, a fracture of the metacarpals, metacarpal dislocation, a divergent carpometacarpal dislocation. We have a fracture of the radial styloid. So we fixed all the fractures. And in this situation, it's not possible to transfer a vessel of the fingers to the thumb. So we use a graft from the digital medial artery of the thumb to the dorsal branch of the radial artery in the snuff box to have the perfusion of the index of the thumb, veins from the dorsal hand to the thumb, tendon transfers, and we have a good result in this situation. We also do reconstruction of the lower limbs. This is a bilateral foot amputation. The left foot, there is a very bad injury, avulsion, and not good tissues here. It's a compression fracture, and the right foot is much better. We have a longest proximal stump of the lower limb also in the right side. So that's the reimplantation of the right foot. That the day of the patient remove the cast, start to use this kind of prosthesis in the left lower limb, and they start to walk. And after 8 years, no usual pressure, showing that the patient has good innervation. We see that our patient has a good index to return to some work using the reconstructed limb and have a good index of satisfaction. And we see that if we consider that 25 years of work, considering the age of our patients, there is a return of the investment in 44:1 for reimplantation surgery. But we also do reconstruction of open fractures. This is the 3C open fracture. So the patient has no perfusion of the hand. We needed to reconstruct the ulnar artery, and we needed to transfer a free anterolateral tie flap, a very big flap from the elbow to the wrist. And after soft tissue reconstruction, it's possible to convert this Kirchner wire fixation to plates and a screw to the scaphoid, and having with this treatment, a complex treatment, but in the acute phase, since the acute phase, a very nice result. This is another example. A 72-year-old female is an open fracture, very severe injury of the wrist, provisory fixation, free lateral arm flap to soft tissue reconstruction, permitting wrist fusion and a nice result. We also help our other colleagues of the trauma and other groups of the university. This is a trauma patient with a necrosis of the skin. It's necessary to do a flap. This is a very simple pedicle gastrocnemius, medial gastrocnemius musculocutaneous flap to treat this patient. You can see the result. This is another case. Free pedicle musculocutaneous gastrocnemius musculocutaneous flap to treat this soft tissue defect. And this is a total knee replacement. And this patient used allograft for patellar tendon repair, and the patient developed an infection. That's a severe situation we see today in our past lecture. We use a pedicle lateral gastrocnemius musculocutaneous flap with a vascularized tendon graft of the triceps with the graft to repair the patellar tendon and for soft tissue recover treatment for this patient. So you can see the result. This is a tumor patient, is a high-grade pleomorphic sarcoma. So this patient, after chemotherapy, radiotherapy, needs a resection of the tumor. So you can see the plan, the surgical plan. The tumor resection is a very wide resection. So this patient needs for limb salvage, unconventional knee replacement, and the soft tissue repair we perform is a simple flap, is a medial, is a lateral gastrocnemius musculocutaneous flap. You can see the vascularized tendon graft from the triceps, and it's possible to repair the soft tissue and to use the tendon graft. Is a vascularized tendon graft, is perfect for the situation. You can repair the patellar tendon and also have the soft tissue repair with the flap. You can see in the acute result, the result of the skin graft and the patient starting rehabilitation. We like pedicle flaps. This is a reverse sural flap. We like for the defects in the ankle and foot. We also use many perforator propeller flaps. We can find the perforator vessels using ultrasound. You can see the perforator flap section, and we can rotate the flap based on the perforator to treat defects in the lower limb. You can see here a perforator flap from the fibular vessels, a propeller flap, and another example from the posterior tibial artery vessel, a perforator for this pedicle. We like to use muscular flap for calcaneus. I know that you can use skin graft, sensitive skin flaps, but I like my cases with muscular flaps. You can see here, this patient plays football, plays soccer. And the latissimus dorsi we also use it for very bad open fractures of the lower limb. And this critical case, this patient has an amputation, a traumatic amputation of the lower limb, there is a severe defect of the ankle. We transfer an anterolateral thigh flap to treat the soft tissue defect, you can see here. And just for another example, this very similar, another patient, but an amputation and a severe defect of the ankle, use a scapular flap to treat this patient with a good result. We also contribute to other areas for brachial plexus and peripheral nerve injuries, for infection, oncology, congenital. For example, this is a soft tissue tumor, a giant cell tumor, wide resection, and we transfer a vascularized fibula graft with epiphysis to treat the defect and to have some function of the wrist and forearm. This is an osteosarcoma of the femur. That's the resection of the tumor group. And the reconstruction that we did is 2 vascularized fibula graft. We turn around 180 degrees to vascularize the other fibula, making the microanostomosis from the distal stump of the from one fibula to the proximal pedicle of the another fibula. So we have 2 fibulas together. We can do that back table. And we have the 2 fibulas, the microanostomosis from one pedicle to the another pedicle of the fibula. And we have just one pedicle here that we can transfer to the femur. You can see here. And that's the vascularized fibula graft. Is a living autologous bone, integrated, consolidated, and we have hypertrophy. We have some cases, I can show you another one with 8 years follow-up, and you can see the good result of integration and hypertrophy. We can do the same thing for the tibia osteosarcoma. You can see the fibula is a small bone, but is a living bone. So the fibula adapted and consolidate, integrated, and have hypertrophy. This is another example of allograft plus vascularized fibula graft to treat tumor cases. We also help the congenital pediatric group in our university. This is a very rare case of congenital pseudoarthrosis of forearm. So after lengthening, we transfer vascularized fibula graft from the fix it proximally to the ulna, distally to the radius or to the carpus. And you can see here the result. That's the patient, the acute phase, 18 years after the surgery. You can see the result. There is good stabilization and a very quite good functional result in a very difficult case. And this is a congenital pseudoarthrosis of the clavicle. You need a small vascularized bone graft to use the medial femoral condyle, using a skin graft or a skin pedicle as a monitor. You have a cortical periosteal vascularized graft with a skin monitor to transfer to the area of the clavicle, and that's the result, and the patient have a good consolidation. We have a lot of brachial plexus injury. You see what happens with the motorcycle transportation in my city. This is a case of upper trunk lesion. And the reconstruction of this patient was the spinal accessory to the suprascapular nerve, motor branch of the radial nerve to the triceps to the axillary nerve, and also motor branches of the ulnar and median nerve to the musculocutaneous, is triple reinnervation. You can see the result that we can achieve. But most of our case came in a chronic situation, so we needed to do transfer, free muscle transfer of the gracilis to the biceps to achieve good results. So you can see a chronic case with good result after muscle transfer. So this is a model that we starting in 1 decade. We have a high success rate about reimplantation. We have for thumb, for example, we achieve 8% of good result for thumb reimplantation. We decrease the rate of complications and intercurrences in the emergency care. We decrease in hospital stay. We have a decrease in the infection rate. So we decrease also the cost of the medical care. Unfortunately, in my country, there is a lack of investment and support and recognition by the health measures to treat the trauma or severe trauma with more support. The country, Brazil, spends a lot of disability, spends a lot of money on disability insurance, treatment of complications and sequelae due to the lack of trauma care policy. So thank you so much for this opportunity. And I'll just stop my sharing screen. And thank you again.
Okay, thank you very much, Professor Rames, for this very impressive presentation with really amazing and very challenging, cases. This needs big expertise, big experience and skills in microsurgery, and also a commitment and a disponibility to work day and night shift. This needs maybe a teamwork, and this is also, in my opinion, the responsibility of the public sector more than the private sector. And we miss really the public sector here in Lebanon. So thank you very much for this very nice presentation. Now the floor is open for the discussion. I don't know how to collect the questions, Yusuf.
From the chat, but we don't. The audience is not really.
We don't have a question.
It is the audience is too shy, but we can open between us. I mean, I have some questions. We start if you, Ali. For the first speaker, any question, any comment? For Dr. Karam. Dr. Karam is there?
Yeah, I'm here.
Yeah, Karam, it is nice presentation. I have a question for you. Do you look at the malnutrition? I mean, is there any relation between malnutrition and total knee or total hip arthroplasty? Do you think something should be looked at, particularly, well, in your States maybe it's not important, but in the Middle East and some countries, it is maybe a major problem. How do you look at it, and if it's really important?
Yeah,
and the second question is smoking. Right. Smoking and arthroplasty.
Okay. So first about malnutrition, I agree with you. It's a very, very important thing to look at. It can increase the wound complications and potentially lead to a high rate of infection. We typically, so at my institution, for all patients, they get malnutrition screened preoperatively. That includes albumin, pre-albumin, transferrin, as well as total lymphocyte count. So those are the markers we look at to evaluate the nutritional status. If the markers are low, then we proceed with giving them protein supplement preoperatively. Even if they're not low, we have a protocol within the week before surgery. We give everybody protein supplement, but if the ones that are low, we give them more in preparation for surgery. The other question about smoking. So this is becoming more and more of a problem in the United States, especially with the change in the reimbursement. So a lot of insurances now won't accept for us to do joint replacement surgery if someone is smoking. Again, at my institution, they have a very hard policy against smoking. Everybody gets a nicotine test before, and if they have evidence of nicotine in the blood, then we can proceed with joint replacement surgery. Other institutions are a little bit more lenient, but I think you have to at least show evidence that you have tried to get patients to stop smoking, at least try to get patients to smoking cessation program, cut down on their smoking status. You know, unfortunately, a lot of the studies showed that even a history of smoking still carries a high risk. So patients, even if they stop smoking, there is already damage to their vasculature, damage to their healing potential. And we're just talking about, you know, from an infection perspective, obviously smoking also increases the risk of anesthesia and perioperative pulmonary complications and cardiac complications. But ideally, we should do our best efforts to try to achieve smoking cessation at least 4 to 6 weeks before joint replacement surgery to optimize the outcome. which I know in the Middle East is very challenging. I always tell people, like, if I have the same restrictions and I work back in Lebanon, I probably can't do a single total joint. But
Thank you.
Henny, there's a question in the chat from Dr. Karim Kantar here in Melbourne for Dr. Abaid. Have you seen it, Ibrahim? I saw you on mute, Ibrahim.
Sorry, I was talking without letting you hear me. So I actually answered by writing to him. So you can see the answer on the question. It was about VBT and the indication of VBT, and he started by talking about the spontaneous correction of the lumbar curve when I was doing thoracic selective fusion, and he was asking about the role of VBT. Actually, if we want to follow the recommendation of the first person who used VBT, which is Peter Newton and of course Stéphane Baron, the in Canada, the indication is are very low, very small, and especially when the patient is immature, before research 0, so research 0 with the triradiate cartilage open, and at the same time you have to have a curve between 30 and 60, so very severe curve. We cannot treat them by this technique. So if we look to all that, we can see that that there's few possible indication if we follow strictly this recommendation. But what we can see now what is actually happening is enlarging a lot the indication with too many complications for these patients. So we are not in favor to use this technique except for very selective cases.
Ibrahim, I have a question for you. Since we have too many general practitioners and we have also some orthopedics that should know the risk factors for curve progression, that should know. All general practitioners and all general orthopedics want to refer the case for a spine deformity specialist. What are the risk factors that you know?
Okay, thanks for this question. This is really the basic question also for general orthopedics to know, of course. We know that let's talk about AIS, so only adolescent idiopathic scoliosis. After that, we can talk, if you want, to early onset scoliosis, idiopathic early onset scoliosis. But let's talk now about adolescent idiopathic scoliosis. The most important is the remaining growth when we discover the deformity. This is the first parameter. The second one is the magnitude of the deformity, the time when we discover it. So these two elements with them we can say this patient need very close follow-up or very aggressive orthopedic treatment, and this one we don't need. Doesn't need a very aggressive follow-up. So if especially this is a woman pathology, and the date of menarche is very important. So if we discover 30 degrees curve, young lady of 11 years, not without a period, and the research sign is 0 with the triradiate cartilage open, this is a very worse prognosis, and we have to treat it very aggressively with corset, and it is one of the rare indication of VBT. On the other hand, if the person is also 13 years old woman, but she has the period since 2 years and she's research 3, and we find the curve of 20 degrees, probably this curve will not progress. So the remaining growth is the most important element, and the angulation at the moment we discover the curve.
Okay.
Thank you.
Ibrahim, my friend Ibrahim.
Yes.
I would like to ask you a question, please. I know that you perform more than 350 spinal procedures every year. And you said that you use only bone graft that you remove from the site of the surgery. I know that around me, a lot of orthopedic surgeons are using synthetic bone substitutes for many commercial maybe issues or something like that. I would like you to stress on this point, because I am a fan of the bone, the native bone use. I mean the real and true bone graft. So I would like your comment on this point.
Okay, I will not be too méchant. I don't know how to say it in English.
Yes.
with all the Lebanese. Actually, corruption is everywhere, and even unfortunately in our community. And I think you see, I do like more than, only in deformity, I do almost 200 scoliosis a year. And for any of them, even for revision cases, I will use bone graft from outside the back of the patient. But for that, we need to know exactly how we can remove the facet, because the bigger amount of bone is coming from the facet, and of course from spinous process. So if you do a large facetectomy, and I have many videos on internet, you can see them, of surgery I made, and if we look to them, you can see how large is the facet when we cut it, and we have to use this bone. This is first. I very rarely use iliac crest. It's very rare that I use iliac crest, because with facet and with the lamina, only the posterior wall of the lamina, we don't open the canal, so we remove only the posterior cortex of the lamina. Using this with the spinous process, with the facet at each level, you will have a lot of bone. And especially if we don't have money to buy these things, and even in France, we can have them. The patient will not pay anything. Oh, the community will pay, but we will not use them because we don't need that. And more than that, this is the most the best quality of bone that you can put in the patient. It's much better than any other bone, than artificial bone, or than hydroxyapatite or anything artificial. This is better to put the bone of the patient himself. So if you do good facet, and don't forget, facetectomy is very important to have the release of the deformity and to be able to correct it. So even to correct the deformity, you need to do the facetectomy. So you use them for the bone.
Ali,
yes.
I have a comment on this. As you know, I am the chair of the NAS Deformity Committee, and there's no consensus about this point. I may agree with Brahim on that. In the very young patients, if you do a good decortication and you remove all the cartilage, maybe not necessary, but deformities are different. It also based on how strong is your implants and the correction, how stable it is. You may not need anything else, but in adults and other cases, you may need a graft. The topic today is not about the graft, but it is not. There's no consensus about this point. But I can agree with Brahim on some cases, young patients, adolescent idiopathic scoliosis, with a good decortication, with the strong implants, you may need not any type of different synthetic implants.
But Hani, the point was just only to stress that the native bone is the only osteogenic, osteoinductive, and osteoconductive. This is the only material that has these three I mean, together. This is
okay.
Okay.
Dr.
Thank
Ali,
you very much.
you have a question, Dr. Ali?
Yes.
Dr. Ali, please, a question for Dr. Karam.
Yes.
Dr. Karam, did you find in your review of the literature any relation between infection and the choice of skin closure? if we use tapers, if you use subcuticular or something like that, please?
Yeah, I mean, there are reports of higher risk of infection or at least wound complications with the use of staple versus suture, for example. I think this is more relevant, especially in the older individuals, like for hip, if we do arthroplasty for hip fracture, etc. So I think the recommendation for the best is to use an intradermal subcuticular monocrystal type suture that would have the least impediment of the blood flow at the skin and allows the best healing potential.
Okay, thank you.
I think Ron, you have a question to ask Dr. Karam. Do you want to come online and ask him directly?
Yes, thank you, Dr. Ahmad. Professor Karam, I have two questions for you. The first one is,
Joe, you can call me Joe.
How do you explain that corticoid injection is a risk factor for infection while they are doing many months before or maybe 1 year before? Is it the immunosuppression, local immunosuppression, or there is another explication for this fact?
Yeah, I mean, I think so. Yeah, I mean, they're done several months before, but also, you know, patients are in pain. You give them a cortisone injection. Sometimes they're pain-free for several months. So that means that the anti-inflammatory effect of the cortisone, of the corticosteroid that you're giving, is lasting a long time. And this is very different with different patients. I do think that again, I don't know that we have hard literature or basic science studies to show how the local immunity in the joint is after an intra-articular injection, but I do think it's from the long-lasting immunosuppressive effect in addition to the anti-inflammatory effect of the corticosteroid intra-articularly that can impede natural immunity as well as other aspects of the immunity at the time of surgery and then lead to a higher risk of having infection. The other theory, which is probably less likely, is that when you do an infection, when you do an injection, even if you asepticize the skin and everything, you may be introducing bacteria in there. So, and then that bacteria may be dormant there for a very, very long time. Like, there are reports showing Staph aureus, for example, living intracellularly, which, we all thought Staph aureus was extracellular, but you could see Staph aureus intracellularly like years, and then, all of a sudden you have an infection. So that can be another aspect of it, but I believe the main thing is the reduced local immunity caused by the corticosteroid. But again, I don't know that we have strong basic science evidence to point to one mechanism or the other.
Okay, thank you very much. I asked the second question. Here in Senegal, and I think in Africa in general, because we don't have always all the sterile conditions during surgery, we give antibiotics for many days, and sometimes 1 week or 2 weeks after a joint replacement to prevent infection. What do you think about this this thing? Is there a utility, a real utility to do that or no?
So yeah, thanks for that question. That's a very interesting question. So this is very controversial. So the official recommendation used to be that you should give a pre-op dose and then stop the antibiotics within 24 hours. The more current recommendation are to give just a pre-op dose and no additional doses. And like I said, there's a big, prospective study going on, few retrospective study that showed that 1 dose versus 2 or 3 extra doses was the same. There's more literature recently. If you look like Mike Meneghini out of University of Indiana, they advocate for prolonged antibiotic treatment for high-risk individuals. So they have protocols where they give, for example, oral antibiotics for 5 days or 7 days. Even now they have recent protocols where they give antibiotics for a more prolonged period in like, revision or high-risk cases. I would say, for example, our protocol for infections, like when we do 1-stage reimplantation or after 2-stage, 2-stage reimplantation, we give antibiotics for 3 months afterwards to prevent recurrences, but this is outside of the scope of the primary cases. But I think the main concern with giving prolonged courses of antibiotics is, of course, resistance and bacterial selection and etc. But like I said, I mean, there is literature to show a role for prolonged antibiotics after the surgery, but this is not the recommendation. No society recommends that, not the American Association of Hip and Knee Surgeons, the Musculoskeletal Infection Society, the CDC, the ICM, all do not recommend any antibiotics beyond 24 hours, even if you have drains in and all of that. So there's no evidence to show really strong support for these practices.
Okay, thank you.
May I put a comment, please, Dr. Karam? Dr. Karam.
Yeah, of course, Dr. Shamsuddin.
Yes, because I think in some hospitals and in some, countries, we may do orthopedic surgery in the same room in which a gynecologist has done a C-section before you, or an appendectomy, or a cholecystectomy, or maybe a TUR of the prostate. So this is why I think in some practices, orthopedic surgeon are more able to give antibiotics for a few days after the surgery. This is why maybe in USA or in France or in Europe, there are dedicated OR rooms, for the orthopedic surgery and for prosthetic surgeries. This is why I think.
Ali,
yeah, I think
the question is, it's effective or not effective? I mean, even if you operate in a room, septic room, you have to know you stay for 10 days, it's effective or not effective.
No, but it's not really aseptic. I mean, when you are working in a room and you don't know what's happening in this room, so maybe psychologically you are more prone to give a longer time antibiotics.
So even in the United States, we don't always, at least like I'm the junior faculty, I don't always get to operate in the orthopedic room, even though I do joint replacement, right? So sometimes you have to, we even have rooms that are interconnected, like there's two rooms that are connected that share the same substerile room, and they're doing gynae cases and like a rectal abscess or something else in the other room, and they're blowing this into my room. So it's not only a problem, in third world countries, but again, like you said, maybe psychologically it makes the surgeon feel better, but I don't know that there is scientific evidence to support, giving prolonged antibiotics.
Sure.
So even if that is a concern, I don't know that giving the extra antibiotics is going to make a difference. We just don't have, scientific evidence to support these practices. That's the issue, I think.
Ali, Dr. Matar is leaving. Dr. Matar is leaving, but before he's leaving, I have a question for you.
Okay,
if you don't mind. No, the question is, have you seen any patient after reimplantation he refused his implant? Some of there are some comments that they don't like it and just ask you to remove the implant. Have you seen any case?
Yes, I remember some. It's not only one. When you have a rigid finger, that's a bad reimplantation indication. Sometimes you reimplanted the index finger is rigid. The function of the ring is worse than without that finger. So at the beginning, I'm working in this field for 40 years. The patient sometimes is corrected to refuse the reimplantation because the hand works better without the finger. But it's just some few cases. That case that I show you of the foot reimplantation, this patient was not happy with the foot reimplantation for about 3 years because they have no sensation, because we have pain. But after that, the foot improved his quality of life. But it depends of the case. You needed to consider just to remove the finger, and we learn with time the correct indication. But most of our cases, the reimplantation is a very pleased surgery for the patient. And the index of satisfaction and return to work using the reimplanted part is very high. So this is an exception. This is a bad indication. Is a reimplantation of one finger, amputation, traumatic amputation, proximal the interphalangeal joint. You try to do the implantation, you achieve a rigid finger. So you have stiffness of the hand because of a bad finger.
Obrigado.
May I make a question to Dr. Ramis before he leaves?
Yes, of course.
Yes, Dr. Ramis, first of all, thank you for your beautiful presentation and the experience you have shared with us. I would like to stress what Dr. Ali Shamsuddin has mentioned about our system here in Lebanon. Unfortunately, we do not have real clear regulations concerning from the Ministry of Health concerning, for example, the hand traumatology. And in Lebanon here, we do have a specialized doctor as a good spine doctors, hand doctors, knee doctors, but we do not have center of excellence. And people doesn't know where to go when they have a problem of hand, for example, and they are used to shop all around before they find the real doctor. So my question is, do you have a system of referral? Do you have a center of excellence in Sao Paulo and a clear system of referral, or the patient has to go to the nearest hospital even if they do not have a specialized doctor for the problem he is looking for a solution?
In Sao Paulo, we have just this public center. This is the referral center for all cases of microsurgical or reconstructive microsurgery, repair or reconstruction. And there is a system of the government try to send all the patients for our hospital. That's caused a big problem because there is a publication that show that the best thing to do is to have one center every 2 to 3 million inhabitants. So the city of Sao Paulo needs about 5 centers working around the clock, and we have just one. But I am talking about the city. If we consider the great city of the state, and we have cases that came from another states. So, and it's very simple to prove for the health system that the organization of a center to treat microsurgery in the emergency and to take care for another groups for intercurrences, that saves money for the country. It's much worse to have the complication, bone infection, to have no soft tissue problems, to have amputations, to have to pay insurance. That's my story of life. I always try to explain to people that just do the politics in health system, that they needed to put investment in this kind of groups. And I believe that my group is a school of reconstructive microsurgery, and try to do to make the people create more groups in not only in Sao Paulo but all around the country. So I really believe that it's necessary to have a good organization with many centers, and if you have the center, the patients came to you. I don't know if I explain you, but
of course. So congratulations for having done that, this initiative to create a center of excellence and a center of hand reconstructive microsurgery. So we hope one day we can have this such a center here in Lebanon, but we still have the need of a clear public health and people education. We need to educate people to go to the real doctor instead of shopping all around. So thank you for your presentation. It was really good. Thank you for the work you are doing in Sao Paulo.
Thank you so much. Thank you for the opportunity. Thank you for the invitation.
Thank you very much,
and I'm so sorry, but I needed to go to the surgical theater just now. I have my team waiting for me. Sorry about that.
Okay.
Bye
Thank
bye.
you.
Good luck.
Bye. Thank you. Thank you for your participation.
Thank you, Dr. Matar, and for these excellent presentations. I think we, Dr. Yusuf, we might conclude
Of course.
this excellent webinar. I would like to say a few words and I'll hand it to Dr. Yusuf. This webinar was fantastic. The caliber of speakers, you know, from the talk from Ryan, and then Joseph Karam, and then we had Dr. Abed and obviously Dr. Matar. It is just, it's amazing and very impressive, and we're proud of all our Lebanese heritage doctors throughout the world. And you know, to see the caliber of work that you do, and what it does translates to the patient care and patient outcome, which is really important. And orthopedic surgery is a specialty that you can have an excellent impact on the quality of life of our patients. We want to continue to collaborate between the orthopedic surgeons, not only outside with part of ILMA, and as also with the orthopedic surgeons within Lebanon, and to form joint collaborations and teaching. And we want this to be ongoing, and this is part of these webinars. I thank all the speakers. I also thank Dr. Ali Shamsuddin and Professor Hani in Spain for being the co-moderators, and Dr. Abdallah, the president of the Orthopedic Society in Lebanon. I thank Dr. Yusuf for also being with me and organizing all these 4 webinars to date. You know, it really makes us proud to see the caliber of our Lebanese doctors throughout the world. And hopefully we all gained something. We learned some magnificent knowledge base today. It's enhanced. And I look forward to our next webinar. And I am biased as a cardiologist. It's coming up on February the 23rd, a webinar on cardiology, but I won't take the surprise out of Dr. Yusuf in announcing it. But thank you very much for tonight. This was excellent. And the questions, we could have gone on talking for much longer. Dr. Ali, yes.
Walid, if you please allow me, I have a personal question to Rayan Saad, if you allow.
Of course.
Est-ce que tu es le fils du docteur Nabil Saad, par hasard?
Oui, tout à fait.
Ah, ça fait plaisir. Je voudrais avoir ses coordonnées.
Oui, bien sûr.
Il était là aujourd'hui. C'est un ancien ami de Grenoble.
Il était là aujourd'hui. So, in English, he
Yes.
asked if I am the son of Dr. Nabil Saad. And yes, it is my father. He is a surgeon, actually in Conakry, in Guinea. And he was today in Dakar for a few hours. I go to see him, to make him a big hug, and he took the plane this afternoon.
He was a very good friend of mine when I was in France more than 30 years ago, and I lost his connections. So I will be glad to reconnect with him. This is one of the favors of this webinar. I mean,
of course, this is one of the aims is to connect
younger
people.
than that.
I'm not very young, Hani. I'm not very young.
Thank you. There we are, Ali. We've linked you with Dr. Saad, brought you back together. But I will give
thank you very much
to Dr. Yusuf to conclude this fantastic webinar.
Thank you, Walid, for giving us the opportunity to organize such webinars. And I would like to thank Professor Amir Abdallah, the Lebanese, the president of the Lebanese Association of Orthopedic Surgery, the two moderators, Dr. Hani and Dr. Ali, and the four speakers with these beautiful presentations and all the information they gave to us, which are really beneficial for our community, which is experiencing, as you know, real economic and social problems. So let me share my screen and give you now an appointment in 3 weeks on Wednesday 23 at 7:30 p.m. with our fifth educational webinar, which will be dedicated to the updates and innovations in cardiology. So thank you again to be with us for this really beautiful webinar, and hope to see you physically very soon in Lebanon.
Thank you.
Thank you very much.
Thank you, Yusuf.
Thank you for the
Thank you,
invitation.
Ali. Thank you, Walid, Dr. Ryan, Dr. Karam, Dr. Hani, and it was nice being with you, Dr. Walid also, and Dr. Abaid from Bordeaux.
It was a pleasure.
Thank you, Yusuf. Thank you. It's a pleasure.
Ibrahim Abaid, we miss you here in Beirut, Ibrahim Abaid.
So you have to go to Bordeaux.
Yes. A good wine.
Hopefully we can all gather together in Lebanon next year, Ali, and bring us all together.
Inshallah.
And I also want to thank Dr. Miriam Missa for the behind the scenes IT in Sweden. Thank you, Miriam, for everything. And she does a fantastic job.
Walid, we hope that next year we'll try with the Lebanese Order of Physicians to organize an official physical meeting in Lebanon here in Beirut.
That's our goal, Yusuf. We'll go. Have a lovely evening, a lovely afternoon, and a lovely morning for you, Karam, here in Melbourne as well with me. Take care, and we look forward. 23rd of February. Thank you.
Bye.
Of course. Bye.
Thank you.
Bye.
Thank you.